sideways, backwards, you know. You need to know the arachidonic acid pain pathway, you know, what the COX-1 versus COX-2s. You have to know about the NSAIDs and which ones are good and what the ones that are just COX-2 inhibitors, which is a bad sign. Let's see. So we talked too about some chronic pain, and if it was neuropathic pain, there are different things and medications that we can prescribe for patients. I would be familiar with those types of medications that might be prescribed for those folks. Like for me, I have chronic pains, I have arthritis in several locations, so I take a COX-2 inhibitor. I have lidocaine patches that I put on the site sometimes. I'm not on any other drugs as of yet for that, but it'll be an idea. But a lot of veterans are, because of long-term pain, they have other things that they're on. Again, know about the arachidonic acid pain pathway. There's a couple, 3 on that one. Ooh, there's another one. I know that sucker really well. No, we talked about, drugs have, some of the drugs have generic names and some of them have trade names. Now, some of the over-the-counter ones, I would be familiar with both names. So, in other words, for ibuprofen, there's also Motrin, I think it's Motrin IV, there's Advil, both of them are ibuprofen, that would be an example of that. Tylenol is also acetaminophen, etc. Patients that have had strokes or heart attacks may be on some medications to thin their bloods out. We haven't talked about it in depth, but we did touch on it. As far as the main thing was the aspirin dosages, so I would understand the difference between the 2 dosages and whether it has adverse sequela if they're taking that and for how long. Another arachidonic acid pain pathway. So after we do some kind of therapy, like we take a tooth out, if a patient is taking some medications for like hypertension, we may or may not give them certain drugs because it can affect how those drugs work. We talked about those specifically with NSAIDs, but there's other drugs too that the patient might be taking that might be rendered less effective with those NSAIDs, or the NSAIDs might cause them to have less control. Kind of understand that concept. When we talked about Vicodin, we talked about Vicodin was hydrocodone. Hydrocodone is now a Schedule II drug. It has to be triplicate form. It works for centrally acting to decrease the pain perception, but the ingredient that sometimes they think, well, I talked to you about using ibuprofen plus Tylenol, those work pretty well. Some people will say, I have to have XYZ, I have to have this drug that has both Tylenol and hydrocodone, but you also need to understand that there's a drug that was manufactured that had both an NSAID and it had some narcotic in it. But I mentioned too with that drug that that didn't work very well, and why was that? And you can expound on that. I mentioned when we talked about antibiotics, there was a drug that is prescribed quite frequently in patients that are allergic to penicillin type drugs. That drug had a bad rap. And the reason it had a bad rap is because it caused a certain problem with the intestinal tract. I would understand which drug that was and what it caused. But I also said basically any antibiotic that is given can cause that same problem in patients. Side effects of some of the antibiotics include different things. I think we touched on that one, the one I'm thinking about extensively in here, so I won't go any further on that. Do know You know, before I've said if you have a periodontal abscess and you don't have a fever, you don't have lymphadenopathy, do we give antibiotics for that? No, we don't. Now, I did skew it a bit today, because I said if the patient's had under chemotherapy, then different story. Right? Then we know they're immunocompromised, and then we would maybe give them antibiotics along the way. So if a patient has a comorbidity, other diseases, right, and they have really bad periodontal disease, would we consider giving some antibiotics for them in their stage of treatment? I would say probably yes. It used to be too, when we had a very aggressive form of periodontal disease, we would prescribe antibiotics. We don't have that classification anymore. All we can look at is the stage and the grade for that patient. So if somebody's a grade C, they may be more prone to needing antibiotics than if they're grade A. We talked about different types of antibiotics, which the ones that we prescribe most commonly in dentistry. I would know those pretty well, like, you know, penicillin, amoxicillin, augmentin, metronidazole. I would know those pretty well back and forward, how they work when they're prescribed. Also, I mentioned that there's one of those drugs that I just mentioned that if you drink with that, you're going to get really sick. And that's because it had an antabuse-like effect. I would know which one that was. We talked about different types of locally applied antibiotics. Did we talk about low-dose doxycycline? Did we mention that? I don't remember. Anybody remember? Maybe we better review it again. Low-dose doxycycline is given for patients that haven't responded to traditional therapy. Because it's at 20 milligrams that's taken twice a day, it doesn't have any antibacterial effects. The only thing it does is it keeps your body from breaking itself down. So that drug is called Periostat if you're prescribing it, but it's essentially doxycycline in a 20 milligram capsule that's taken twice a day. So for patients that you've done scalar surge debridement, they didn't respond very well, you think you got all the calculus, that might be something we might prescribe for them. Or if it's a perio patient that has had surgery, gone through the whole 9 yards and they still didn't respond very well, sometimes I would do that. As I mentioned, I had one patient that her 600-pound niece moved in with her. Remember I said she went under a whole bunch of stress and she had increased breakdown of her probing ducts as a result of that. And that would be an option. In fact, I did prescribe it for her because she had started smoking again, she had stress, all the different things. And I gave that and it helped to stabilize her a little bit. We talked a little bit about how patients that are screened for tuberculosis, and then what happens if that screening comes back positive. We talked about some of the drug therapy that's prescribed for it, as well as what's next. If you have your PPD taken, you know, your little welt is huge on your arm and swollen up, then what's next after that to determine whether you have tuberculosis or not. We also said if we have a patient that has active tuberculosis, we know treating, right? Send them away until they're under control. Usually if they've been on medications for, say, a few weeks, then it's probably safe to treat, but not until then. When we talked about antivirals, we also talked about some of the different types of viruses that we see commonly in the mouth. HSV1, HSV2 are possibilities, and where they found the first time, where they found after that first exposure, you know, as far as the HSV1 particularly. And what are some of the drugs for patients that, you know, just have continual outbreaks of herpetic lesions? What can we prescribe for that? We talked about antifungals, and we mentioned different types of medications that are available, some of which we are concerned about, some of which are not as concerned about. Sometimes patients can put them in the mouth and let it dissolve. There's one particularly that we said, we don't like that one too much because it has high caries, it has high sugar content of it. So we dwelled a little bit on HIV when a patient with HIV becomes considered an AIDS patient. There was a certain CD4 count that we looked at. I would know that. That's our I would understand about bisphosphonates, you know, why they're used for cancer patients, why they're used for osteoporosis patients, what are some of the precautions with that. If a patient's going to start cancer therapy, you know, what are some of the things we should think about doing for them before they start? Give you that example of that last guy, total endodontia. Remember I said when we give a fluoride rinse to a patient, or a patient has a fluoride rinse, it can last a long time. You know, it lasts in the saliva for several hours. I don't know about how long. I said if you had too much fluoride, there's several things that can happen. One was my grandma, her tummy hurt, sick to her stomach, nausea. The others can, with the increased dosages, can be more deadly. Oh, I did that right. Okay. So there is one question about how much fluoride a 12-year-old should have. Okay, whether they live in a community that has fluoridated water or they don't have fluoridated water. So if they don't have fluoridated water, they don't live in a community that has it, you would assume there's no fluoride in the water. So, at least for a 12-year-old, you need to know that. Okay, and there are 50 multiple choice questions with one extra credit. So you can miss one, still get 100.